I'm Heidi Daniels. I'm the Vice President of Development at the American Liver Foundation, and I'd like to welcome you all to this webinar on liver health and primary care. We have a great listing of presenters today that'll be sharing some information with you regarding liver health and how we are really trying to partner with the primary care physicians to help catch this diseases of the liver early as possible. I would like to remind everybody again that we are recording this. We will be posting this on our YouTube channel so you can refer back to it, and we'll also be sending it out to other practitioners. So please make sure your phones, unless you're speaking, your phones are set to mute. That would be helpful. We would ask that you put questions in the chat. If you have questions for a presenter while they're talking, just put it in the chat, and we'll definitely leave time for questions and answers. So please have this be as interactive as possible. And I would also like to take this opportunity to thank Genentech for their sponsorship of this event. They've really partnered with us to make this happen and really find value in making sure we bring this type of education program to our primary care physicians. So I'd like to thank you all again for being here. It's my pleasure now to introduce two physicians that'll give you an overview of the evening and talk more about the purpose and goals of what we're doing today. Dr. Strazzabosco is the co-director of the Yale Liver Center, and Dr. Tamar Taddei is the Chief of Digestive Diseases at the VA Connecticut Healthcare System. So we're really thrilled to have them both here, and they've been on the committee planning it. So I know it's an exciting day for them to be part of this. So thank you both for being here and for your work on this program.
Thank you very much, Heidi. Really, it's great to be here. I'll try to share my slides now, which is a task that I usually fail. So bear with me if you can. I hope you can see them.
You did it.
Can anybody confirm? Yes.
Yes, okay. You did it.
All right, great. So what we would like to achieve today is to send a message that hepatology care is about to change. And we should, this slide is taken from a recent publication from the Lancet Commission on liver disease. And what I was saying is that the current organization of liver care is the management of complication. And that happens usually in an environment which is connected with very large healthcare center that can manage that. But this is about to change. It's about to change because, as you know, most liver diseases can be prevented, but prevention requires coordinated action. Also because some of the major risk factors for liver disease are actually very huge problems, from obesity, diabetes, lack of exercise, and in addition to hepatitis, alcohol use disorder. So there are several levels in which we should intervene. And currently, these interventions are disjointed. In fact, as shown here, there is the ability to provide economic and social stability, physical environment, literacy is actually at the level of the government and the public policy. But then the application of this intervention to the population is in contact with the domain of family doctors and then the family practice that happens outside the hospital. So the intervention for risk reduction and the early diagnosis of patient individuals that are at risk for developing more serious liver disease is the place where the specialist in liver disease, the hepatologist, has to interact with the primary care physician. And several of our speakers today will really talk about this. So these two actions need to happen before the patient reaches the hepatology division and the healthcare center, because at that time, we can only manage the complication. And so the message here is basically how to integrate primary care hepatology and advanced care hepatology. And we realize that this is a conversation that is just beginning. So we're just trying to drop some ideas and throw a stone on the pond. Thank you.
Thanks, Mario. I just wanted to give an overview of the talks for this evening, and we're going to keep these talks fairly brief. We wanted to leave some time at the end for questions and discussion. So we're going to have our first talk. I'd like to introduce Dr. Catherine Mezzacappa. She's a clinical fellow in digestive diseases at Yale School of Medicine. And she's going to be talking about liver disease risk factors and identifying patients who need to see a hepatologist. She's done a lot of research in this area, and we're delighted that she can speak to us tonight. So Catherine, I'll turn it over to you. And when you're finished, I'll introduce Dr. Jakab after that.
Thank you very much. So I'm going to see if the magic of slide sharing will work more than once. Here we go. So as Tamar mentioned, I'm Catherine Mezzacappa, and I'll be talking about risk factors for liver disease and the epidemiology of liver disease and methods that we recommend to identify which patients need to see a hepatologist. I really appreciate you coming today or listening to this recording after the fact. A brief outline of what I'll go over in this presentation. I'll first talk about the epidemiology of liver disease, talk about the tools that are available to screen for advanced liver disease, and when to engage hepatology for a patient who warrants specialty care. So in terms of the epidemiology of liver disease, the most common risk factors for advanced liver disease in the United States include hepatitis C virus, which may be ongoing and chronic or cured. There are a number of older adults who have had a cure of their hepatitis C virus with direct-acting antivirals. And just a reminder that all adults should have at least one-time testing for hepatitis C virus. Steatotic liver diseases, this is a new categorization, even in the liver world. It is a grouping of what used to be called fatty liver diseases. And it encompasses the spectrum of what is referred to as metabolic dysfunction-associated liver disease, or formerly non-alcoholic fatty liver disease, to alcohol-associated liver disease. There's also hepatitis B virus, which can cause chronic liver disease, more rare autoimmune liver diseases and cholestatic liver diseases, and heritable metabolic liver diseases. And these last three groups, these are individuals who should really already be engaged in specialty care, and if they're not, can be referred for that. So I'm going to focus on these top two groups, and in part to focus on just the very prevalent conditions that present with steatotic liver diseases, and the fact that liver disease is multifactorial and can progress due to somebody's accumulation of risky exposures over time. So an example of that would be somebody who had hepatitis C virus. The virus was cured with drug treatment, but then with aging and metabolic disease, maybe has progression of liver fibrosis despite cure of their viral disease. In terms of the most common causes of advanced liver disease, this graph is actually the end stage of liver disease. These are individuals who are on the wait list for liver transplantation. So they have very advanced cirrhosis. But I think it's a nice visual representation of the overall trend that we are witnessing in liver disease. And what you'll notice is that these turquoise lines, which represent what used to be called NASH, or fatty liver disease, and alcohol-related liver disease, have been increasing, while the number of people being listed for liver transplant for hepatitis C virus has been decreasing since we had the introduction of highly effective therapies to cure hep C. And the combination of NASH and alcohol And the mixed disorder, which is being referred to as combined metabolic and alcohol-related liver disease, are these steatotic liver diseases as a group. So when we think about who is going to have progression of a steatotic liver disease, I want to point out just how common it is for individuals to have deposition of fat droplets in liver cells, which is the condition of hepatic steatosis. It's about a quarter of American adults, so that's 66 million adults. And the vast majority of those individuals are not going to develop life-limiting liver disease. They're much more likely to have a cardiovascular disease or non-liver related cancers be the main life-limiting medical condition for them. And when we talk about progression, what we're really talking about is fibrosis. Liver fibrosis develops due to the presence of chronic inflammation, and we stage it from F0, which is a normal liver, to F4, which represents cirrhosis. And there are all of these intermediate stages along the way with their pathologic descriptions listed there. And on average, in steatotic liver disease, somebody may progress about one stage of fibrosis every 7 years. But the reality is that it is not a linear process, and the average does not represent each patient. So in reality, it looks something more like this, although this is a conceptual image, where some people represented by the red line will progress in fibrosis quite rapidly. Some people might develop fibrosis, but more slowly, and never develop cirrhosis over time. And some people may never develop any meaningful scarring in the liver. And the difficulty is distinguishing between these groups. Unfortunately, our standard liver chemistry does not give us a great amount of discriminative ability for this. So this is just a bar graph showing the proportion of individuals who had an ALT level greater than 35 across different pathologic diagnoses when they had a liver biopsy. And you can see that the red bars, which are the proportion of individuals who had an elevated ALT, and the blue bars, which are people who had completely normal ALT values, which were considered less than 35, show that the absence of an abnormal ALT value is not necessarily reassuring against the presence of steatohepatitis or advanced fibrosis. So we can't rely on that alone. One special situation I'd like to point out is the relationship between type 2 diabetes and liver disease. The evidence showing that individuals with type 2 diabetes are at a different risk of developing progressive liver fibrosis is accumulating. For example, this is one study that looked at individuals who were at least 50 years old and had type 2 diabetes. They were identified from either primary care or endocrinology clinics, and they staged their degree of liver disease. 65% of the sample had NAFLD, which we now call MASLD, but deposition of fat in the liver. 14% of these individuals with diabetes had advanced fibrosis, and 6% had cirrhosis. And these were in people with previously undetected liver disease. So this has led to the recommendation from the American Diabetes Association and several European societies to actually screen for liver fibrosis in all patients with type 2 diabetes. So what tools are recommended to screen for fibrosis when you're thinking about your patients who either might have a history of hepatitis C, they may have metabolic disease, or they may have moderate to high risk alcohol consumption? The tests that are recommended are the FIB-4 score, which is the simplest to calculate and requires only a liver chemistry, a platelet count, and the patient's age. And the NAFLD fibrosis score, which was really developed specifically for metabolic related liver disease. The NAFLD fibrosis score does require a fasting glucose and an albumin level in addition to those other metrics, and so may not be as easy to calculate for all primary care patients. And then once you calculate this score, this is a graphic from the American Association for the Study of Liver Diseases guidance statement on non-invasive testing. And I'll walk through what the recommendation is for these scores and the thresholds. So at the very far left, in individuals who have non-fatty liver disease, so maybe somebody who had their hepatitis C cured but is not living with metabolic disease, if their FIB-4 score is less than 1.45, or if they have fatty liver disease and their FIB-4 score is less than 1.3, or the NAFLD fibrosis score is less than negative 1.455, you can essentially rule out advanced fibrosis. On the other end of the spectrum, if an individual without fatty liver disease has a FIB-4 score higher than 3.25, or in the setting of NAFLD, a score higher than 2.67, or a NAFLD fibrosis score greater than 0.676, then that is highly suggestive of the presence of advanced fibrosis, and that person requires follow-up with hepatology. And in between, we have indeterminate values that require what we call confirmatory or secondary assessment. Those tools for secondary assessment are essentially tools to estimate the liver stiffness. And liver stiffness correlates with degree of fibrosis on biopsy. The two most common methods to do so are vibration-controlled transient elastography, or you may have heard it referred to as FibroScan, the brand name of the machine. And in addition to providing an estimate of liver stiffness, it will also provide an estimation of the degree of steatosis or fat deposition in the liver in the controlled attenuated parameter or CAP score. A second option is MR elastography, and this will provide both a liver stiffness measurement and a degree of steatosis measured using something called the proton density fat fraction. So when this is applied in real-world practice, I just want to point out how common it is that patients at risk are identified. So one study performed in France assessed over 2,000 patients with no known prior liver disease who were being seen in general practice. And they found that almost 20% of them had an abnormal FIB-4 score using a screening mechanism. Here in the United States, in a cohort in Vanderbilt, there were multiple gaps in the cascade of liver disease screening identified. So the first panel of this visual abstract shows that about half of the total population lacked the data elements necessary to calculate a FIB-4 score, so either a liver chemistry or a platelet count. It was rare for individuals who had an abnormal liver chemistry to be referred to hepatology, and a very small minority of patients with an elevated FIB-4 score had confirmatory elastography. So there are numerous gaps along this pathway for us to work on together. And I'll show one final graphic to go through just how you would do this in practice. So what is recommended, and this is from the AASLD guidance on diagnosis and management of fatty liver disease, is to, in a primary care setting, where the goal is to exclude advanced fibrosis in a population that's going to have low prevalence of this condition, the primary risk assessment is meant to do that. So you first perform a FIB-4 score. And if it's less than 1.3, then you can just recheck that every 1 to 2 years, or sooner if you develop clinical suspicion for liver disease. If it's greater than 2.67, you could consider directly referring to specialty care. Otherwise, if it's in between 1.3 and 2.67, or in the case of non-fatty liver disease, greater than between 1.3 and 3.25, you would perform the secondary risk assessment, which is typically recommended to be the vibration-controlled transient elastography, or FibroScan. If that indicates low risk, you can again return to just reassessing every few years. But if it's intermediate risk or higher, you would refer to hepatology for further assessment. Or otherwise, if there's any persistent abnormal liver chemistry, that would be another reason to refer to specialty care. So to summarize, You would engage hepatology if the initial FIB-4 score is high enough to be suggestive of likely cirrhosis, or an indeterminate FIB-4 score leads to secondary testing, which results in either an intermediate or high risk of advanced fibrosis, or for a persistently abnormal liver chemistry. So I'll wrap up just with some take-home points. The first is that chronic liver disease is multifactorial and that it is silent until it is advanced. So it really requires us to think about it and apply a case-finding approach. All adults should have testing for HCV, and after cure of HCV, liver disease can progress and individuals can become reinfected. So it's just important to always think about that in persons at risk. And to screen for liver fibrosis in patients with a history of HCV, individuals who are consuming alcohol either currently or have a history of doing so, and really just to assess alcohol use on a routine basis for all patients. And finally, to screen for liver fibrosis in all patients with type 2 diabetes and consider it in others with metabolic syndrome. And I'll stop there.
Thanks so much, Catherine. That was fantastic. I mean, I think it's really important to sort of set the stage for what to be thinking about in the office setting, and sort of when to refer in the sort of, the walking, liver patient who comes to you to probably be seen for many other things, and you begin to think about liver disease. So taking us from the office to the hospital, I'd like to introduce.
We do have a few questions. You want to answer them now or at the end?
I think we should save them to the end.
Okay. All right.
Yeah, but definitely jot your questions down in the chat and we will absolutely field them at the end. So it's my pleasure to introduce Dr. Simona Jakab. Dr. Jakab is an associate professor of medicine in digestive diseases at Yale School of Medicine. She also directs the Yale Liver Home, as well as our inpatient liver service. She'll be talking about the importance of collaborating with tertiary centers for patients with cirrhosis. Simona, thanks so much.
Thank you very much for the introduction and for the invitation. So I will get this started. Do you see one screen or two? Do you see presenter mode or?
Yeah, we see presenter mode.
Okay. Got it. Okay. So, again, thank you for inviting me to talk about a very important topic, and I hope this way we can work together to better serve our patients. To talk about decompensated cirrhosis in 15 minutes, it's very tricky. So I'll give you the very, very brief overview of decompensated cirrhosis, and then we'll talk about multidisciplinary resources available at tertiary centers and how we can work together to help our patients. As you heard from Catherine, there are several chronic liver diseases out there that we should monitor for progression to cirrhosis. Cirrhosis is truly what changes the game when it comes to management of many of our patients with chronic liver disease. But there are many phases of cirrhosis. So once our patients get a diagnosis of cirrhosis, they go home, they start looking up stuff, and you get very scared phone calls asking about, do I need a liver transplant? So we have to do our best to educate our patients and our colleagues about the different aspects of cirrhosis and how we can manage patients at different points in their journey. So although I will focus mainly on decompensated cirrhosis, I just wanted to give you an overview. So patients with compensated cirrhosis are those who really have no much symptoms in terms of their liver disease. Sometimes, most of the time, actually, their blood work can be abnormal, but overall, they are doing quite well. Once they develop complications such as variceal hemorrhage or ascites or hepatic encephalopathy, and this is what we call decompensating events in cirrhosis. This is when we see a significant decrease in their survival. So, for example, patients with compensated cirrhosis, their survival is in the range of 12 to 15 years. A lot of times they die because of other comorbidities rather than their liver disease. But once somebody develops decompensated cirrhosis, the survival can drop to less than 2 years. And the patients that we see on our liver service are patients who are in a even a more advanced stage, what we call further decompensation. They come with recurrent variceal bleeding, refractory ascites, and other complications. And when they get to this point, it's less likely that we can intervene to recompensate their liver disease. So their only curative option remains liver transplantation. There are a couple of scores you should be aware, what you see in our notes from the liver clinic. And this is a way for us to guesstimate prognosis in patients with cirrhosis. So the child score has been used for many, many years, and it gives you a global view in terms of survival at 1 year and 2 years. So patients with child A cirrhosis, they are mostly compensated, and you can see survival is in the range of more than 90% at 2 years. But as the decompensations occur, patients with child C cirrhosis will have a survival less than 50% at 1 to 2 years. And the MEL score is what is being used in different iterations now for organ allocation for liver transplantation, but also gives you an idea about the 3-month survival. The MEL score is the only validated score to assess survival. It was validated in a cohort of patients waiting for liver transplant. But just be careful how you use it. So as I was talking in the clinic with one of the patients about the MEL score, and I told them, you have a MEL score of 15. This is not bad. The survival at 3 months is more than 90%. What the patient got out of it, that he had a 10% chance of dying in 3 months. So I got calls back from his psychiatrist because, again, things can be misinterpreted. So even patients with decompensated cirrhosis are sort of our very sick patients in liver clinic. Please keep in mind that we can offer many treatments that can help these patients. Starting with, in some patients, we can actually reverse their decompensation state. So patients I meet in the intensive care unit, they come with severe alcohol-related hepatitis. They have several decompensations. If they stop drinking, it may take a while, may take 6 to 12 months, but now I follow quite a few of these patients, more than 10 years. They do great. They have their life back together as long as they can maintain abstinence. So not everybody who is decompensated will necessarily have to get a liver transplant, or they will die because of their liver disease. And treatments of diseases such as hepatitis B or autoimmune hepatitis can reverse decompensation. Hepatitis C gets a little bit tricky. The other important treatments that we offer for patients with decompensated cirrhosis is management of their specific complications, but also we try to stay ahead of the game a little bit and try to prevent further decompensation. So if somebody presents with variceal bleeding, we try to prevent a secondary variceal bleed, or if they have one decompensation, we try to prevent the occurrence of the other ones. Liver transplantation is a very important treatment for this patient population because in the setting of irreversible decompensation, this is the only life-saving treatment. So certainly it's not available in all centers, and it's very important as a community provider to be aware of your closest transplant centers. But I just wanted to point out these patients have many challenges related not only to the severity of their liver disease, but just managing their liver disease in terms of complications from treatments, need for hospital admissions, procedures. It's very hard for the patients, for their families, and also for us as providers. We need to make sure we accommodate them for very for close follow-up, for monitoring, and that's why it's so important to keep an eye on the big picture and make sure that we get to discuss goals of care and we introduce palliative care to these patients, because some of them will get worse and will die. Last but not least, interventional radiology has brought major advancements in how we treat complications from portal hypertension. So our colleagues can achieve portal decompression by using a stent put inside the liver, connecting a hepatic vein branch with a portal vein branch. This is effective in treatment of recurrent ascites or variceal bleeding. They can also help with different types of shunts to achieve peritoneal decompression for palliative treatment of ascites, for example, tunnel peritoneal catheter, sort of the Pleurex system, or rarely used now, although theoretically should has an important role, is a peritoneal venous shunt, which drains ascites directly into the systemic circulation. Last but not least, collateral obliterations. So obliterations of varices or other spontaneous portosystemic collaterals using coils or plugs or a combination with glue is a very important treatment for treatment of varices or recurrent portosystemic encephalopathy. Talking about the big picture, the other challenging aspect of managing patients with decompensated cirrhosis is that we are not seeing a linear progression of the disease. So you cannot plot, get MEL scores checked in 1 month, in 3 months, in 6 months, and sort of guesstimate where the patient is going to go. And actually what we see is patients doing sort of okay, then something happens, they end up in the hospital, they get better, but maybe not as good as they used to. And then it's sort of this decline, which, as I mentioned, is quite challenging for both patients and their families, and also the uncertainty of what the future will bring is quite challenging. So that's why it's very important for our patients' quality of life to keep in mind that collaborating with palliative care can actually prolong their life and, even more importantly, increase the quality of their remaining life, and by all means is not antagonistic with liver or life-saving interventions, but it should be used together. So management of patients with decompensated cirrhosis is very complex, and as you can see, there are many ways we collaborate across subspecialties, but including need for those patients to be hospitalized, again, to see consultants across various fields of medicine. And ultimately, we all hope to improve the survival for our patients, or at least their quality of life, or to get them successfully to transplant, or if they have severe disease leading to death, to help them achieve what we call a good death in their own terms. But last but not least, regardless of how excellent we are, and at Yale we have a long history of excellence in hepatology. Not too long ago, we celebrated our Diamond Jubilee, 75 years of Yale hepatology. We have to keep in mind that the patients and their families have to navigate sort of the day-to-day life. So even if we have international experts advising us how to take care of these patients, we try to follow the guidelines. Is that much patients can do if they cannot afford to adhere to a low-salt diet because they don't have access to good quality food, high protein, food, or they cannot come for their appointments or their procedures because they don't have access to transportation. So the social determinants of health are fortunately much better incorporated now in our clinical practice, and we try to help our patients from that perspective. But regardless of all these advances in our understanding, not only about the disease process and the treatment, but also trying to navigate the challenges that our patients face, what most happens in most centers is a very fragmented care, and the patient and their families are kind of lost trying to get their way to see various specialists and try to do their best to follow the medical recommendations. Sometimes I joke, but I mean, it's true, for the family member who needs to help a liver patient is a full-time job trying to keep together their appointments and getting their medications and so forth. So we recognize this, and for a few years now, we are trying to put together a multidisciplinary patient-centered program to better help our patients with cirrhosis. So this is what Dr. Taddei referred as the Yale Liver Home. So we have some pieces together now. We have a paracentesis clinic to allow rapid access for our patients, so they avoid ER visits or hospitalizations for treatment of their ascites. We have a social worker. We have access to behavioral health. We might get soon a community health worker to assist patients with their appointments, make sure they are aware of resources in terms of transportation and anything else they need, help with insurance, help connecting with the system. We have a better access to outpatient palliative care. This was missing for a while at Yale. At the VA is much better access when it comes to these supportive services. We were able to start some patients on remote patient monitoring. That's still a bit limited. And there are several areas we are still trying to get more resources and work on it. But ideally is for all of us working to help patients with cirrhosis to come together and to meet the patient where they are and where their needs are, without having them to navigate this very complex medical system. What we still have to figure out is, now that we have all the pieces together, is to see how we can introduce this to our outreach community in terms of referral process and how we will actually use this resource. So for the last few minutes of my presentation, I just want to give you a bit of a tour, the force of specific challenges that we have when managing this cirrhosis decompensation. So if you are a provider who has to take care of a patient with a variceal bleeding, there is a lot of things you can do locally, either in the primary care office or using or collaborating with the local gastroenterologist. But there are a few things, again, I think it's important to be aware where us as a tertiary care center can help you. And we have to work together, because realistically, as much as, ideally would be for us to be able to see at least once all patients with cirrhosis, or at least all patients with decompensated cirrhosis, we won't have the capacity to meet this need. So we have to work together. So just to give you some examples, for example, a patient with variceal bleeding needs to be treated to prevent a repeat episode of variceal bleeding. So we rely a lot on use of beta blockers. We have to use non-selective beta blockers to achieve the desired effect. So as a primary care provider, if you have somebody on metoprolol and they have cirrhosis, you might consider to switch them to carvedilol or a non-selective beta blocker, because that can help with their portal hypertension. And if they're on a non-selective beta blocker, again, the access to remote patient monitoring is not there yet, but people have Apple Watches and they have Fitbits, and they have all sorts of other devices. So you can create a plan for the patient to be able to monitor their heart rate, in blood pressure in real life. In terms of endoscopic treatment, many of these treatments can be done by local GI. Of course, we are happy to help in a tertiary care center, but ideally is for us to help patients who get sort of more complicated. For example, they cannot take non-selective beta blockers, or they have other types of complications such as portal vein thrombosis, and we have to figure out different ways to treat them outside of the routine treatment, which is beta blockers and endoscopic treatment. We do have at Yale a portal hypertension conference specifically designed to discuss these complex patients. So we can figure out what's their best treatment for them, interventional radiology, advanced endoscopy. And last but not least, of course, some of these patients would benefit from transplant evaluation. When it comes to management of ascites, we have to rely a lot on our patients' local care for day-to-day management. And repetition is very important. If all of us keep telling our patients the importance of low salt diet, importance of high protein diet, also titration of diuretics. Again, we are happy to help, but it might be easier for the patients to have sort of local connections. If the patients need paracentesis, probably it's easier for them to get it done locally than to travel all the way to a tertiary center. But certainly we would like to help patients who fail the sort of the basic treatments, or they progress because they would benefit from alternative treatments such as TIPS or other shunts. Those patients can develop complications such as spontaneous bacterial peritonitis, hepatorenal syndrome, and certainly that's when they benefit from a tertiary center care. And of course, when it comes to transplant evaluation. Again, in terms of monitoring for these patients, the phones are very smart these days, so the patients can choose an app that it's easiest for them to manipulate, to track their weights, or paper and pencil still works. It's all about establishing a system and for all of us to use them. For patients with hepatic encephalopathy, the main treatments remain laxatives such as lactulose or Miralax for patients who cannot tolerate it. In some patients, there is a clear benefit of rifaximin because it prevents readmissions for hepatic encephalopathy. Rifaximin should not be used as a first line. It remains quite expensive. We should be mindful of prescribing rifaximin in the right patients. It's very important, as I said, to optimize nutrition in these patients in terms of high protein diet for the longest of time. Patients were told if you have hepatic encephalopathy, you should not eat protein. We aim to achieve to get patients to eat 1.5 grams per kilo of protein per day. So gets them around 100, 150 grams of protein. And what's most important, try to avoid checking the ammonia level as an outpatient because the numbers will be all over the place and will really not change management and will just cause extra stress for the patients and their families. And talking about the family involvement, hepatic encephalopathy has the highest caregiver burden, and it's sort of the scariest complication of cirrhosis because their family members see them sort of getting confused, getting agitated. So it is very difficult for them to manage. When it comes to what a tertiary care center can bring to improve the treatment of these patients, as I mentioned, portal hypertension conference is where we discuss complex patients and where interventional radiology can help is if we have patients where we identify that the main driver of hepatic encephalopathy is abnormal vessels that shunt the blood away from the liver. It's what we call spontaneous collaterals. Those shunts can be embolized and they can be life-changing. This can be life-changing for patients avoiding hospitalization and a significant improvement in their mental status. If you have trouble getting patients rifaximin, we work with specialty pharmacy, and they have ways to connect patients with the patient assistance program. Again, trying to use all the resources available to benefit our patients, and as I mentioned before, by all means, transplant evaluation. So I'm going to end with a plea that yes, it's very scary to take care of patients with cirrhosis, but we all have to work together, because a tertiary care center cannot completely manage these patients by themselves, but we can certainly help with many aspects involved in management of patients with cirrhosis. We are very happy to get involved early on, especially when it comes to patient family education, discuss prognosis, help them understand the role of liver transplantation. Certainly we have several options if the routine regimens fail. We have access to different ways to treat cirrhosis these days, many of them relying on a multidisciplinary approach. Again, the benefit of having a tertiary care center, but feel free to reach out for any questions at all, and hopefully we can do a better job for our patients. Thank you.
Thanks, Simona. That was great. That was like a whirlwind tour of liver disease. I'm going to just briefly end with talking a little bit about HCC. Let me see if I can share my screen. Let's see, I want to share this one. Okay. So I just want to talk briefly about who and how to screen for hepatocellular carcinoma, and what to do and how to refer when you find a mass. So HCC is very challenging because it's pretty unique among cancers. Basically, people with cirrhosis have highest risk for HCC. And so there's one patient with two diseases. They have underlying liver disease, and then they develop a cancer. And cirrhosis leads to multifocal liver cancer because of the field effect of the scarring and inflammation that happens over many, many decades in the liver. And because of this, they have very high recurrence rates. So cirrhosis also complicates treatment and trial design because you have to think very carefully about underlying liver disease and liver dysfunction. And most oncologists are used to designing trials in patients who have normal platelet counts, good protein stores, et cetera. And so they're already starting with patients who are sick at baseline, which has made trial design quite challenging. And HCC is the only solid organ malignancy that can be diagnosed by imaging alone, meaning you can definitively call a cancer without doing a biopsy, which has its pros and cons. And it's also one of the only solid organ malignancies for which transplantation offers a cure. So the onus is on us to identify those transplantable patients, because they would have 30 years or more of survival with a liver transplant, getting rid of their cirrhosis and their liver cancer. Now, HCC is a leading cause of liver-related and cancer-related mortality. It is the leading cause of death and cirrhosis. And about 85% of people with liver cancer have cirrhosis and some underlying predisposing liver disease. Most of this is viral hepatitis, but also alcohol-related liver disease, as well as more commonly now, metabolic-associated steatotic liver disease. But these patients come to us already having cirrhosis. Their risk ranges between 1 to 5% per year on average, but that risk can go up, especially if somebody has multiple risk factors, for example. Now, this is 1 to 5% per year. Okay, so keep that sort of in contrast with colonoscopy, which we do for colorectal cancer screening. Patients who, sort of average risk patients who undergo colonoscopy, they have like a 1.5% lifetime risk of developing colon cancer. So we really need to identify the people who would benefit from HCC screening, and it is those with advanced fibrosis and cirrhosis. Now, about 15% of people who develop HCC can develop it in some underlying sort of liver disease that may not have cirrhosis. So they could have perhaps a healthy liver. Many of them have a fatty liver or some degree of fibrosis. And we really don't know how to detect this 15%. So, we're not sure what their risk is. We need to do much more sort of research to try to understand composite risk scores for these patients and sort of the additive or synergistic effect of multiple exposures. But this population does keep us up at night because right now there are really no guidelines for screening this group. And just to keep it in perspective, in terms of global deaths, it's the third leading cause of cancer death globally, and it claimed over 800,000 lives in 2020. And of course, the projections are about 1.3 million deaths attributable to HCC by 2040. So this is not going away, and it's unfortunately not getting better. And sadly, 5-year survival is still at around 20% overall, but it's very important to know that it's 70%. So 5-year survival is 70% when HCC is caught in early stage. So this is really important. We have to detect these patients as early as possible. So again, it's a global health problem, and you can see that it's essentially attributed to a lot of different etiologies. What is important is the sort of yellow piece of the pie here, which is essentially fatty liver disease or steatotic liver disease, which you can see is a very big portion of the pie in North America, but it's also becoming a big portion of the pie globally. And as we get more effective vaccine programs for hepatitis B, and as we cure more people of their hepatitis C, we're going to see steatotic liver disease as a prevailing risk for liver cancer. So the epidemiology is changing. Now, we screen with ultrasound and AFP every 6 months in patients with cirrhosis and chronic hepatitis B. And for chronic hepatitis B, they don't need to have cirrhosis. It's really anybody with chronic hepatitis B. And that's really important because you need to know your viral status of your patient, and you also need to think about cirrhosis and think about liver disease. Some gray areas are those people with steatotic liver disease without cirrhosis, as well as those who've attained a sustained viral response or Hep C cure in patients who were cured of their Hep C without cirrhosis. And many patients can have Hep C for many years and not develop cirrhosis, but they still have sort of the insult and inflammation of the virus. When that virus is cured, we really don't know sort of how their risk changes. We do know that their risk persists if they had cirrhosis, but this particular group also keeps us up at night because we're not sure what their risk is over time. So once you have a mass on ultrasound or a high or rising AFP, then you need to think about how you're going to follow that patient. So if the mass on ultrasound is less than a centimeter, you can repeat that ultrasound in 3 months. But if the mass is a centimeter or more, or the alpha fetoprotein is over 20 or perhaps rising, then you would want to do a dynamic contrast enhanced CT or MRI. This should be ordered as a liver protocol CT or MRI because it needs multiple phases in order to really detect what is a liver cancer. Now, liver cancer surveillance saves lives. We know this. This is just a big meta-analysis of almost 150,000 patients recently published. There have been many, many studies. Essentially, we know that we can detect cancer at earlier stages with surveillance, that we can offer more curative therapy, and that ultimately we can prolong survival. Now, unfortunately, a lot of these studies are not randomized controlled trials because randomized controlled trials are very hard to do in this population. They've been tried. Most people don't want to sign up for a non-screening arm. So places where we lack data here are things like harms of screening, which I'm sure you've read a lot about in both breast cancer and prostate cancer. We think harms of screening in HCC for HCC are fairly low because an ultrasound is a pretty non-invasive test, but of course it's pretty onerous to come every 6 months for an ultrasound. And so everybody's looking at things like biomarkers or more sensitive tests. Now, it's important to know in the United States, we do a really lousy job of screening. In fact, of the people that we know have cirrhosis, only about 20% are actually in any kind of routine surveillance program. The vast majority are not. And that's why we do a very poor job of this overall survival, which remains at 20%. In places like Japan, where they screen about 75% of their patients with cirrhosis, or the UK, where they screen about 65% of their patients with cirrhosis, their survival rates at 5 years are, much higher than ours, approaching 50%. So we have a long way to go here. And then I think the biggest thing for primary care is this huge iceberg underneath the ocean of undiagnosed cirrhosis. So linkage to liver cancer, care starts with identifying cirrhosis and starting surveillance. And primary care providers really need to be educated to suspect cirrhosis. You have so much on your plate. I think it's really important to think about liver disease. Liver disease is a very common cause of mortality across the globe, but I think it's not something we think about every day in the routine care of our patients. Now, this slide is just to show you a staging classification for liver cancer, and I don't want you to really look at this other than to say, my gosh, that's super busy. And it's really important to note that we really have to think about liver function first before we start counting tumors and their locations. So tumor burden is relative in liver cancer. We really need to understand liver function first, and then we can stage according to their liver function and their tumor burden. And it's important to know that there are a lot of different therapies that we can offer for patients with liver cancer. And in fact, these therapies are growing by leaps and bounds. And in the last decade, we've seen a bevy of systemic therapies, immune checkpoint inhibitors, and small molecule therapies to help with liver cancer. And you can see that people who have earlier stage disease have, an expected greater than 5-year survival, and then that survival starts to drop off as their disease becomes more advanced. But even those who have significantly advanced disease should expect about a 2-year survival, even with non-liver directed therapies or systemic therapies, as I mentioned. It's really important also to note that we really think a lot about the patient, their own decisions, their goals of care, et cetera. And so there's the expected survival. We know that we have to think carefully about people who might have liver cancer confined to the liver, but sort of in multiple places in the liver. We really should be thinking about systemic therapy in these patients. We can also downstage a patient so that they can become eligible for more curative therapies. And again, treatment stage migration is really important because we can think about transplant even in patients who might have had pretty significant tumor burden at the time of diagnosis. Again, don't forget, we have lots of systemic therapy now, and so we have to work very closely with our partners in oncology. So the bottom line is we really need multidisciplinary cancer care for liver cancer. And this is a picture taken from a recent review, a sort of playbook where the hepatologist serves as the quarterback for the football team of all these different stakeholders like radiation oncology, hepatology, pathology, et cetera. Our tumor boards are a little bit different than general oncology tumor boards, but it's because there are a lot of different therapies that we can offer. And we need to come together to define the endpoint. We have to improve survival in our patients, but survival is relative to both liver disease and liver cancer. We have to come together to properly select patients and to perform a thorough risk assessment. And we also need to set standards as a group of people who care for patients collectively. We have a lot of variations among disciplines, and so we need to come together where there are gray areas. There are also variations among programs and regions in terms of, for example, liver transplant programs, et cetera. So we have to identify optimal candidates for therapy and identify contraindications. And then we have to care for that person along the continuum of their care, of their cancer care and of their liver disease care. And now we're seeing people living for many, many years, which is really great, but it requires a lot of effort. So what's the bottom line? As a primary care doc, I think it's really important to learn to suspect and recognize liver disease, to screen for HCC with alpha-fetoprotein and ultrasound every 6 months in patients with cirrhosis and in patients with chronic hepatitis B. And if you have a mass over a centimeter on ultrasound, or if your AFP is rising, get a dynamic contrast enhanced liver protocol, CT or MRI. Refer early to a multidisciplinary care center, and these are invariably tertiary care centers with both liver expertise and a dedicated tumor board. And I think I'm going to stop there and open it up for questions. Let me see if I can stop sharing too.
Great. Well, thank you. Thank you all. Those are very informative presentations, and we appreciate you spending your time with us. I do have a question to start with for Dr. Mezzacappa. How would a primary care person follow a patient cured from hepatitis C?
Thank you for that. So it depends a little bit about the patient. So not all patients who had their hepatitis C virus cured are the same. Early in the days of hepatitis C treatment, pre-treatment liver biopsies were typically performed. And there is a period when we didn't have non-invasive tests to estimate fibrosis. So for a person who had cirrhosis, so stage 4 fibrosis prior to cure of their hepatitis C, you would continue to follow them with the routine screenings that we recommend for all individuals with cirrhosis. For an individual who maybe you don't know their fibrosis status or it was intermediate, I would think about their additional risk factors that may be accumulating over time. So there are some people who also live with chronic hepatitis B virus who have been cured of hepatitis C virus. There are people who may have concomitant alcohol use disorder that's either in remission or active. And then as people age, aging is a main risk factor for fibrosis. It's sort of present in all of us. Or as people accumulate cardiometabolic comorbidities, I would think about all of those things together. So a person who had no fibrosis at all and whose hepatitis C was cured and they have no other risk factors, I would think about differently than somebody who had advanced fibrosis at the time their hep C was cured and perhaps has other risk factors for progression of liver disease. What I would say is to think about not only the one-time measures and things like their liver chemistry and their platelet count, but to look at trends over time. And so if you get annual labs on your primary care patients and you see that the platelet count has declined from, normal, maybe 300,000 or 250,000 to 190, 170, 140, and you're sort of seeing a trend over time, I think that should be a trigger to repeat a fibrosis assessment. And to generally sort of take the approach that I described earlier, which is to calculate the FIB-4 score every few years, especially in people with additional risk factors like metabolic disease or alcohol exposure.
Great, thank you. I hope that was good. Dr. Jakab, when should patients with cirrhosis be referred to hepatology consultation?
So again, my wish would be for all patients with cirrhosis to be able to see a hepatologist, but this is unlikely that it's going to happen anytime soon. So I would say at the minimum, at the first decompensation, they should have a hepatology assessment, and then the future visits would depend on what we can offer to the patient in terms of reversing the original liver disease or in terms of future development of complications. But at the first decompensation, they should see a hepatologist because those patients might benefit from early evaluation for liver transplantation.
Okay, well, thank you. Dr. Taddei, is ultrasound sensitive enough for HCC screening, and what does AFP add?
So ultrasound alone is not terribly sensitive. It's somewhere around 50% in terms of sensitivity, which is not the greatest for a screening test. If you add alpha fetoprotein to ultrasound, you get around 65%. It's very specific, but not sensitive. So I think we need to find better screening tests for HCC, and we also need to find sort of who are the populations that benefit most and what interval do they need to be screened at? Because I think every 6 months is a pretty, it's a pretty high bar for patients to come in and get an ultrasound every 6 months. I do think that in the next 5 years or so, 5-10 years, we'll probably have better data on, how best to screen and in whom. But for now, ultrasound is a very safe, very non-invasive test. It's very easy to get. And it's actually, it's fairly sensitive for larger lesions. So generally speaking, the things that we worry about being missed on ultrasound are more sort of infiltrative disease that we can actually also miss on dynamic imaging sometimes. But for the garden variety liver cancer, if you have a 2 centimeter lesion, chances are it's going to show up on an ultrasound. We have a lot to do in science. We need to get much better at both risk prediction and in screening. And there are many clinical trials ongoing, both in biomarkers and imaging analysis, et cetera. So I think the future is brighter, but we definitely need to move the needle in this area.
Yeah, I would agree. Dr. Mezzacappa, FibroScan is not so readily available. Is US elastography a good alternative?
Mm-hmm. So when I hear ultrasound elastography, I think of shear wave elastography. If any of the hepatologists on the call disagree, let me know. So the tests, none of these tests are perfect. And so what I would say is when we're putting together a picture of whether or not a patient has advanced fibrosis, I would use the test that you can get. So if hopefully FibroScan will become more available in the community, but if it's not available, if you have a combination of sort of your clinical assessment of the patient, the trends in their lab values over time, and an ultrasound elastography or shear wave elastography, those can be put together into a sort of mosaic that even if it's not a photographic picture, you can get the sense of whether or not it suggests the presence of advanced fibrosis. And if there's discordance between the tests, I think that that's another scenario in which asking for help from a specialist is helpful, because each of these tests, they're good and they are valid, but no single non-invasive test is perfect. So I would say use the test you have access to and consider it in the context of the trends you observe in all the other markers in the patient.
Great. Dr. Jakab, what are complications after TIPS?
As much as I think TIPS is a great choice for many of our patients with specific decompensation of cirrhosis, patient selection is very important because number one, we have to make sure we do the TIPS for the right indication. Lately, we've been recommending TIPS for earlier stages of ascites. So for example, if somebody has large volume paracentesis performed 3 times in 1 year, they should be considered for TIPS rather than waiting when they have to have paracentesis every week. But having said that, after TIPS, we can see worsening of hepatic encephalopathy, heart failure, liver failure. So patients need to have testing before TIPS to make sure that we help them with the TIPS rather than harm them. The most common complications is hepatic encephalopathy because the blood would go through the TIPS, through the stent, rather than be filtered by the liver. So it's important to have patients aware of these complications. Some patients can no longer drive after TIPS, or they really have to take medications such as lactulose and have to get bowel movements every 3 to 4 bowel movements a day to maintain their mental status. So this can significantly alter their quality of life.
Okay, thank you. Dr. Taddei, when should someone refer a patient with liver cancer to an oncologist or to a transplant center?
So that's a great question. I think part of the problem is the referral patterns are very haphazard, which is really the beautiful part about multidisciplinary care. When you have a multidisciplinary care center, ideally you have a centralized referral, which allows people to bring the case for discussion and decide what's the proper plan of care for that patient. Because basically, if you have sort of a diversity of ideas, you may come up with a much more robust plan than if that patient sort of goes to see the oncologist and then goes to see the surgeon and then goes to see a transplant hepatologist and then goes to see an interventional radiologist. So, there's this adage, just because you can do something doesn't mean you should do something. I think when you have really great minds at the table thinking about what really should be done for this individual's cancer in the context of their liver disease, their wishes, et cetera, then you can really come up with a great plan. I think as a hepatologist, I'm perhaps biased, but I think it's great that we're sort of the honest brokers of these patients. We don't perform the surgeries, the transplants, the interventional radiology techniques, or give the chemotherapy. We actually really sort of get to know the patient, explain to them what their condition is, sort of are very clear on, what is cirrhosis, what is liver cancer, where do they meet, what are the potential options. And so I think, having a hepatologist gatekeeper model is probably certainly the way I prefer to practice. Mario may chime in here. But I do think that that it's best to actually come up with a plan and be seen even in a multidisciplinary care setting. So you don't have to go see all the individual people. You can see the people who are going to be carrying out that plan together in one place. And that even includes, the addition of palliative care services, because, getting the diagnosis of cancer is really distressing. And a lot of patients and their families need that extra support from the palliative care folks as well.
What I can add to what Tamar so beautifully exposed is that, and she said that, but it's really important to refer this patient to a center that has a multidisciplinary program, a functioning one. It can offer all the possible treatment. This is a key. And we have learned how to manage this and how to make it working.
Okay, thank you. And I have one more for Dr. Mezzacappa. What do you do differently if you demonstrate fibrosis in a patient with MASLD?
Mm-hmm. So I think there are a few things that are important to finding fibrosis in a patient who's living with MASLD. So the first is that I think having a conversation where you share with somebody that there is evidence of chronic injury to a major organ is just really important. I've had multiple patients who, when they get referred to us and have a fibroscan and we talk about the presence of fibrosis in the liver, it sort of changes how they understand their metabolic health. Not because they didn't care about it before, but because they're aware of this measurable difference that has occurred. And they are understandably worried about progression. The other thing is that we know that there are ways to reverse fibrosis and reverse the process. Metabolic disease is notoriously challenging to treat. I think that depending on the patient and their other metabolic risk factors, in addition to MASLD with fibrosis, they may be eligible for other kinds of management. So in individuals with class 3 obesity or class 2 obesity and multiple complications of obesity, that may be a patient I would talk about bariatric surgery with, because that's a very effective treatment for metabolic disease and MASLD with fibrosis. But there are other, emerging therapies that can help with weight management that I'm sure everybody has heard about, like the injectable GLP-1s, as well as the more traditional advice about diet and exercise, which for, the evidence shows do not lead to large amounts of weight loss for most people, but for some people will have an effect. And so I think consistency, the way that Dr. Jakab described earlier, is important in messaging. So and finally, what you can recommend is drinking caffeinated coffee. Actually, seems it looks like the evidence is accumulating that it has some benefit for fatty liver disease and prevention of fibrosis. So if a patient likes coffee, you can wholeheartedly support their caffeine habit. And if there's significant fibrosis, there's the first ever FDA approved treatment for MASLD with fibrosis. At this time, it's very expensive, and I don't think it's the kind of thing that is likely to be prescribed in the primary care setting right now because it's very new. But there will be emerging therapies, hopefully, now that we have a paradigm for drug approval that can rely on non-invasive tests without liver biopsies. So what you would do differently, I think you would think very hard about treatment options for metabolic disease, and depending on the degree of the presence of or degree of obesity and other risk factors, maybe have a conversation about bariatric surgery or other weight loss therapies. You could recommend coffee. You would certainly be sharing that they have a chronic disease related to their metabolic disease, which may change the patient's perspective. And in the future, hopefully we'll have additional therapies as well.
Great. Thank you. Dr. Jakab, who should and when should goals of care be discussed?
Thank you. This is a very important question when it comes to patients with decompensated cirrhosis. So usually goals of care or palliative care is sort of more established in patients with cancer. That's when people sort of pause and they think, okay, what to do next? So it may not come as a first thought, somebody has decompensated cirrhosis, we should have a discussion for goals of care. But the truth is that, and to quote Dr. Taddei, we can do a lot of things in medicine now, but it doesn't mean that if we can, we should do all these things, all sorts of interventions, readmissions, without checking with the patients that this is truly what they want. The patients have a tendency to kind of go with the flow, what their doctors recommend, and maybe not necessarily question us with our recommendations, even if they're deep inside, they really don't want to be back and forth to the hospital, and they actually would value more time with their family than to be stuck in a ICU hooked up to machines and all sorts of other things. And if patients want to keep doing this type of invasive treatments, is perfectly fine. Again, the most important thing is to be concordant in terms of their goals of care with what we offer them. It's proven in cancer and even other chronic liver disease that involvement of palliative care or hospice care, when things get sort of towards the end, improves quality of life and survival, because patients don't get complications from procedures that really are not going to make a difference. And again, there are also several studies looking at how many invasive procedures patients end up getting in their last 6 months of life, which could be better spent otherwise. So in terms of who should do it, I think anybody who feels comfortable and has an established relationship with the patient. As a subspecialist, we may bring up, we certainly will talk about prognosis, but it's hard to start a goals of care discussion when, from the first appointment. If we see these patients after a hospitalization or other, what we call sentinel events, something that significantly happens in their disease course, that certainly opens the door to reflect of what happened in the hospital. Is this really something that you want to be done if it happens again? But certainly the role of primary care providers who know these patients for much longer than we as subspecialists know them cannot be stressed more. We should be partners in this and share this responsibility. Thank you.
Yeah. Great. Dr. Taddei, can people with advanced liver disease tolerate liver cancer therapy?
So that's a great question. I think when a person has decompensated cirrhosis, we have to be very careful. And in fact, when a person has developed ascites, if it becomes refractory, if they are not a transplant candidate for any number of reasons, I will usually have a sort of shared decision-making conversation with them about the fact that if we found a cancer at that late stage of liver disease, really end-stage liver disease, it's adding, insult to injury. And it's probably time to stop HCC screening. So that's a tough conversation, but it does need to be had because, it's very tough to be told you have cancer, but hey, there's nothing we can do about it. Most people with well-compensated cirrhosis, and even those who have early sort of decompensation or child B cirrhosis that can be brought back into sort of a steady state, they actually can tolerate therapy, and they can tolerate both liver-directed therapies and they can tolerate systemic therapies. The systemic therapy trials were done in patients with Child-Pugh A cirrhosis. So only one trial was, one or two included early Child-Pugh B. That Child-Pugh score is sort of a combination of different things, both blood work and whether the patient has ascites or encephalopathy. Child's A cirrhosis is sort of silent cirrhosis. You'd never know the person had cirrhosis to look at them. So I think we need to think carefully about how best to care for our patients to keep them in the best possible state for liver cancer therapy. And that's a lot of what we do in clinic. We make sure that they're getting adequate protein, that they're, all of their cirrhosis health maintenance is being, carried out. And we also are very vigilant about if they develop signs of decompensation, of rapidly trying to get them into a steady state so that they can tolerate therapies. So the answer is yes, people with advanced cirrhosis or advanced liver disease can have cancer therapy, but those who have end-stage liver disease where they have a competing risk of death from their cirrhosis, which is the prevailing risk of death, then in those patients, we would really counsel them to not be screened and also to avoid therapy that could hasten their death if it caused liver failure.
Yeah, absolutely. Those are the questions we had in the chat. I know that there was one question from Ivan that has been answered, that the benefits of fish, especially fish high in omega-3s, far outweigh the risk of not having them. They've seen nothing associated with salmon with hepatic steatosis. So thank you for that question, Ivan. And I wanted to see if there's any other questions or to see if there's any, closing comments that Dr. Taddei or Dr. Strazzabosco would like to make, and then I'll close the program.
All I like to say is that, as we said at the beginning, this is the start of a conversation. We need to move liver care from the hospital to the community, and that's the only way to prevent the trouble. We can fix some of the troubles, but not all of them. And so working together, it will probably be successful. And this is, I think, our message. So let's continue to talk.
Great, I agree. It's a great start to a dialogue. I would like to take a moment and just let the people attending know that the ALF has support programs for patients. We have a liver cancer Facebook support group. So if you do have patients that have liver cancer, it's a great vehicle for them to get support. We also have a Masled MASH Facebook support group. So as you're getting more and more patients who are diagnosed with a metabolic disorder, that's another really great group. And we always have our helpline, which is available to patients. But we have chat and regular, on the phone like normal people. Would do, back in my day, the normal thing was to be on the phone, but not to be chatting. So I did want to bring that up. I also wanted to talk about really quickly our Think Liver, Think Life initiative. It's a public health awareness program that ALF has started. It's in its third year, and it does education, awareness, and screening the liver cancer of liver disease. So it's a variety of things. I put the link to the website on there. Please take a look at it. There are resources that we can provide to primary care physicians to help support you in screening and finding out ways to help your patients that are diagnosed with liver disease. So I wanted to just state that really quickly as well. And I wanted to thank all of you for attending. I would love to thank all our speakers. You guys did a great job. I'd especially like to thank the Yale Liver Center for providing the speakers and getting everything coordinated, especially Dr. Strazzabosco and Dr. Taddei. Really appreciate your planning in the planning of the program. And I definitely wanted to take one more moment and thank our sponsor, Genentech. They really made this possible to help really get this dialogue and this conversation going. So I wanted to thank them as well. So we appreciate your time, and we will look forward to continuing this conversation.
Thank you.